Merci beaucoup, Yves, pour cette introduction très chaleureuse. And I will also now switch to English and be grateful that everyone else can understand me better when I speak English than if I try at this moment in French, although it is a wonderful language that I've been trying to learn for the last 20 years. But I think we can do this in English better for me. I'm going to be grateful also for this wonderful three-part series, and I feel honored to begin it. I know the two other speakers, one of them I have met, Diana Koo, and I think she's also online. So I think that this is a fabulous series that the university has put together. I would just say that our unit, which is relevant to our conversation, is part of the department at WHO that has 5 other units for each life stage. And our unit is really the life course unit within WHO. And I think this is relevant as we think about not only for older adults and healthy aging, but of course the cumulative importance of health development and aging. So I'd like to talk about 4 areas. I may skip some slides quicker, but basically I would like to brainstorm together on, during the discussion on what implications this has. But I would like to, as I was asked, to give some insights on the concepts of healthy aging and the operational approach WHO has taken so far, and also describe some of the key findings from a recently released baseline report for the new UN Decade of Healthy Aging that we just had endorsed both by WHO member states and by the General Assembly of the UN. And connect this to the importance of trajectories and life course, but not in great detail because I think Diana will be doing, Professor Koo will be doing that next time. And a little insight on research and evidence, not so much detailed research questions, but in a sense, what is it that WHO is trying to promote in this area? So just to start with healthy aging, in 2015, we produced a report on aging and health, and we outlined 3 key components of healthy aging, with the goal being improving functional ability. And functional ability combines the intrinsic capacity, or the mind and body of an individual, and their interaction with the environment that they live in. And the intrinsic capacity is both the physical and mental capacities a person can draw on, and the environments are really specific to that individual, but also over time as they change, and it's where they live and conduct their lives. And environments can either be supportive or enabling, or they can actually hinder what a person can do. But the idea for healthy aging is that an enabling environment can make up for declines in intrinsic capacity of the individual. And that is what we mean by optimizing functional ability. And we have some ways to try to describe that a little bit more. What I think is important is that we have drawn on the WHO International Classification of Functioning Disability and Health to develop these categories. And we also have done a lot of discussion and reviews in terms of what matters to older persons. And so for each of these areas, of course, they're very vast, we need to be able to operationalize it. And for functional ability, what we have identified in discussions with older adults and literature reviews is that there are 5 major areas, you could consider them as domains, that are relevant for older adults to optimize, as these are the areas that if they have the ability or the opportunity to optimize these areas, then they can actually be and do what they value. In a way, we're drawing on Sen's capabilities framework and thinking that if you have the resources, then you have the equal opportunity to achieve your approach to well-being. So we're not defining for each older adult what exactly they should be able to do, because each older adult should be able to make that decision themselves. But the areas, of course, we start with are basic needs like having food, shelter, and clothing. This is really around human rights, the basic rights, and having those being able to. So, so just to say that staying mobile means being able to get where you want to go. So it's not only whether you physically can get where you want to go, but what are the services around you that can enable that. But also being able to build and maintain relationships, continue to learn and make decisions, and a very broad category of being able to contribute to family and communities. We have a short animation, which I will make the slides available, and you can click and look at it, which tries to describe this in a very kind of simple way. But what we've done then in order to unpack this, to operationalize it, is we've looked at these different domains of intrinsic capacity, including locomotive capacity, sensory capacity, vitality, cognitive capacity, and psychological capacity. And we've tried to see, well, you know, for older adults, these are the ones we have identified through that process of looking at the International Classification of Functioning Disability and Health, and also informed by older adults' views. And we've looked at that in relation to, for other age groups, what does...
Ritu, excuse me to interrupt you once again. We don't see your slide for a couple of minutes, for 2 minutes, I would say. Great. Thank you.
I don't know why that happened. I'm very sorry. Usually that doesn't happen. Okay, so we have identified these domains, and we also are looking across other life stages to see where the literature has identified domains. But our focus really is on older adults for looking at what is the current data availability to try to actually assess each of these domains. So we've also gone through a range of surveys from around the world, both nationally representative as well as those that look at maybe more smaller clinical populations, to try to understand what are the different ways these domains have been assessed. And for intrinsic capacity, we have focused on those which have been performance tests, some type of test. And I'm just showing examples which we have documented in this baseline report, which I'll talk about in a moment, so you can see all of these sort of details. But for example, for the cognitive area, we've tried to, working with our colleagues across WHO who work on each of these specific areas, see which types of tests are most comparable and have been considered as a good approach to assess a range of capacities within each domain. So we try to identify, for example, for each domain, at least 3 or 4 existing approaches, because we wanted to see what can we actually document now. And although we were able to identify existing items or tests, when we actually looked across all the surveys that are nationally representative to see what data is comparable, for the area of cognition, the only item that we could find in 40 plus countries to maximize the number of countries that we had data for was the 10-word delayed recall. For all of the items related to physical capacities, we only found one item related to hand grip strength. So even if surveys are collecting information, there is not enough commonality across surveys, or there's still a lot of missing data when we actually got the surveys to see what is the quality of data. So we had sort of two challenges to overcome in identifying questions that could assess these different domains of intrinsic capacity. We did the same for the environments. We tried to understand what information, how to cut up the environments. We came up with 5 domains related to products and technology, the natural and built environment, the support and relationships that individuals give, the attitudes that people have, but that these attitudes can then also influence the way policies and regulations, whether they're discriminatory or actually enabling, and then broader services and systems that support specifically older adults. And unfortunately, we were not able to find any individual specific surveys that had information both on intrinsic capacities as well as on the outcomes of interest on functional abilities, and also with environmental data. We could find individual studies, but we were unable to find a large number of studies that had such environmental information. When it came to functional ability, I mentioned the 5 domains. We also looked at the types of questions, and we were unfortunately only able to find questions that were comparable without a significant amount of missing data in relation to some areas of basic needs. There are a lot of other questions that we identified for all domains except the ability to learn, grow, and make decisions. And that's an area we're trying to see if we can find from smaller studies appropriate ways for people to respond to assess this particular domain. So with that background, for the baseline report that we released last December, we developed with a network of researchers and institutions a range of inputs to complete this report. We put together a transformative pathway to optimize functional ability, which draws on WHO's existing research, knowledge translation, and scale-up strategies, and I will show that later. We conducted 8 national case studies with ministries of health and leading other national institutions that considered what kind of data they have, and more importantly, how are they using that to actually make decisions to support older adults. And I'll give one example later. We have 10 progress indicators that at the national level, countries have agreed to in our global strategy for aging and health back in 2016, and they have recommitted their desire to be monitored in a sort of a collective approach in the progress in these 10 areas. And I will show something about that as well. It's very important because this is the self-accountability mechanism that countries have agreed to be able to monitor progress on what they're doing in terms of national policies and their implementation. We also have, we had commissioned 10 different research studies with many different principal investigators in different countries. We also conducted 12 evidence syntheses. Cochrane Campbell Global Aging was a key partner in enabling this. Through our regional offices, as you know, WHO has 6 regional offices, including the one in Copenhagen, Denmark, that is for the 53 countries in the European region. We had them collect examples from a range of, from all countries that showed what is being done to actually address the needs and rights of older adults, from a range of pilot studies to national programs. And through a rigorous process of peer review, we selected about 40 that are highlighted in the report. And I really encourage you to read the full report to see these, because we use these 40 examples to illustrate this transformative pathway. Finally, we were able to identify 55 nationally representative studies of older adults age 60 and over, so that we could identify which we could measure healthy aging based on those questions that I showed you earlier. And from the 55 existing nationally representative studies that were at least from 2013 or earlier, subsequently, we were able to get 53 of them, and we were able to identify from those 42 countries that had comparable data. And I want to show a couple of examples. But before that, I'd just like to say that the report and our overall approach puts older adults first. And we want to make that really clear. We work with two really important global civil society organizations. One is Help Age International, that has self-help community groups with older adults in 70 countries around the world. And another is the International Federation of Aging, that is a federation of national associations of older adults, also close to 100 around the world. And we're constantly working with them to see how we can ensure that what we are doing is, on one hand, meaningful to older adults, and the other hand will also be relevant not only to national policies, but also to the groups that are organizing older adults and promoting their needs and rights in every country. And this in the report, we highlight some terrific older persons who have been leaders and also demonstrating that they can accomplish, and they continue to accomplish, extraordinary things at all ages. So in terms of the decade of healthy aging, which starts this year in 2021, member states or countries have identified 4 key areas for action. One is to change how we think, feel, and act towards age and aging, and this is to combat ageism. The second is to ensure that communities foster the abilities of older people, and this is really about the environment. Recall having that enabling environment that can optimize functional ability. A third area is about delivering person-centered integrated care and primary health services that are responsive to older people. This is critical as a key component of what is expected from WHO to provide clear guidance on how can we better organize care so that it is coordinated and that it's focusing on the overall needs of older adults and recognizing that there is a huge diversity in the types of needs for services, whether it's preventive, promotive, treatment, rehabilitative, or palliative for older adults. Finally, which is very much connected, a fourth area is to provide access and to build up the systems for long-term care for older adults, older people who need it. And I think I'm not going to go into any detail whatsoever in this talk about COVID, but we have in the report and on our website quite a bit of information of what we have been trying to do to address the issue of, for example, long-term care facilities, and how COVID has basically exposed the importance of not only thinking about long-term care in isolation, but really what can be done in terms of home services for older adults and also community services for older adults. I've also listed the core persons in each of these areas at WHO in our Geneva office who are responsible to coordinate actions. So you can also follow up with them individually. The report itself lays out kind of a narrative in 5 sections. We start off with getting ready for the decade of healthy aging, and that's where we have some of the conceptual issues of what is healthy aging, why we take a both social determinants and equity and life course approach to it. Also, we provide a baseline on where we are now, reflecting the analysis of those 42 countries with comparable data. We also have a section where we talk about what can we expect to improve, given that we have 10 years ahead of us, and we look at different indicators of progress. Finally, we think in more concretely how we can actually improve together using those 40 examples from around the world that we curated. And then we end with what can be done in the next 2 years, because we know that the decade is 10 years. It may seem like a long time, but 10 years goes by very quickly, and the UN has asked WHO every 2 to 3 years to provide a progress report on how we're moving forward. So this is also a place where we hope to foster and collaborations. And Eve knows what we've been doing with the WHO Consortium on metrics and evidence for healthy aging, but we also have other opportunities for researchers, research institutions, and also civil society groups to participate. So I would like to give just a couple of examples from the report in terms of findings. Starting with functional ability, I mentioned that we only had some data for meeting basic needs. We had data from about 127,000 older persons in 37 countries for this subset. The y-axis shows the score, which is a good score, is a higher score, 100 is better. And the x-axis shows age from 60 to 100. And basically, each colored dot is a different country with the mean of that age group in that country. So what we see is that as age increases, fewer older people have the ability to meet some of their basic needs. When we extrapolate our results globally, a key message is that at least 142 million older persons worldwide are unable to meet some of their basic needs. As I mentioned, a key sort of obstacle for us to claim this is really global is that we only have about 25% of member states with comparable data. We have 194 countries. We only had 37 with data in this area. But what is important is we want to be able to monitor all areas. But I would like to show one more example from this, because we did look at results by age, sex, and education levels, and education levels as a marker of socioeconomic status. And based on this data from 37 countries, what we see is after age 80, that women are significantly less able to meet their basic needs than men, with the gap widening with increasing age. However, in many high-income countries, because most of the data is from high-income countries, but not all, differences by gender are much more important than education levels. And this really points out the potential vulnerable situation of older women around the world. But it's really important to note that men and women in some countries have relatively high scores at all ages. And this indicates that at every age, people can be supported to meet their basic needs. Because for functional ability, as it is also a reflection of your environment, there is no reason that we see this drop-off with increasing age, because if the environment is supportive, we would want to see that people can optimize their functional ability. So if I turn to just one example from Intrinsic Capacity, where we had data from one domain from vitality, and we used hand grip strength, which I think many of you are familiar with. What we are showing is here that we had 121,000 older people in 36 countries with comparable data. And we have here a 7-layered distribution, which shows 5-year age groups. the better score is on the right side of the horizontal axis. With every 5-year age group, the distribution shifts to the lower end. This is not surprising that the youngest age groups in orange and yellow on average have higher scores. But at every age, including among adults aged 90 and over that make up the purple distribution in the front, there is a lot of diversity in people's physical capacity. The same is the case for the one measure we had of cognitive capacity. And this underlines that there is no typical older person, and policies and programs need to be informed by disaggregated data. I don't have time to show more details, but we have more information in the report and the detailed background paper that provides the analyses, background and methods. For environments, I mentioned that we had no comparable data on environments, but what we did look at is 9 indicators that are related to the age-friendly communities network. And we saw distance and travel time to some aspects of the natural and built environment and places or services that older people would like to go to, like parks, social clubs, or health services. And we pulled this information from Google Maps using a systematic protocol, kind of accessing what you can through your smartphone, but we did it through a protocol which allowed us to map a grid of each city and then sample different locations and then put this information together. And what we were able to do for each city was to show a dashboard from around the world that indicates how far and how long by walking, driving, or taking public transportation that you can get there. And this is, you can't see the details, but the dashboard for Tokyo, and particularly a highlight on that in Tokyo, getting to a park is really close, both by distance and time, pretty much wherever you are in the city. But the key message is that environments clearly play a crucial role in promoting healthy aging, and using the UN speak for ensuring no older person is left behind, meaning in terms of equalizing opportunities for accessing services and places that you want to be. But what's really important for this local data is that people can use information about their locality from multiple sources to actually then develop actions and different programs. And in the baseline report, we provide a lot more detail on how that is being done in different places. But bringing this together, what we're trying to understand then is, what does this mean, not in terms of just a snapshot, because that's what we could give in the baseline report, but really if we look at trajectories and the more dynamic nature. So we've taken an approach that we should really track trajectories. And in this particular figure, where we look more at the second half of life, we want to be able to see how those 4 key action areas I mentioned for the decade, in terms of overall, how are we looking at improving approaches to combat ageism? How are we improving health systems and long-term care, and also the environments through very specific sort of public actions that look at that address population policies that are implemented, to also actions that are specific to different communities or also to individuals. And what we want to see is, if even when we know that people have high and stable capacity, and then there can be a place of declining capacity as well as a significant loss of capacity, but what can be done in the environment to really bump up this functional ability. And I think Diana, Professor Koo, is online. We have very much benefited from her and her center's work. And we very much want to credit that this thinking, from going from the epidemiology to what actually can be done, it largely reflects the work that she's really been able to catalyze our efforts. So we want to see how can we enhance reserve, how can we delay decline, and then how can we modify the rate of decline when it occurs. And we know this because this matters because perhaps only 25% of the trajectory is determined by, let's say, genetic or some factors that are unmovable. But we have 75% where we can actually do something about this if we work together. So in the report, we also highlight some activities, research results from other partners, not only research that or analysis that we did specifically for the report. So this slide shows one result from the ATLAS study where they reanalyzed existing longitudinal studies. So they looked at about, I think it was about 15 studies where they had more than 130,000 older people, and they looked at a 10-year period. And what they found was they could develop 3 different trajectories. And they found that there was a trajectory about a little more than 70% of older people were in a high and stable trajectory. And the data that they use combines information on intrinsic capacity and functional ability. They came up with 1 score as their healthy aging score. And they found, which I think is really important for us, they found a trajectory with a fast decline, which was about a little more than 3% of people who started out high, but had a quick decline over the 10-year period. And then there was also about a quarter of the population that started out low, and they kind of were in this low, stable trajectory. And of course, we can consider what can we do to enhance reserve, to identify those people who are potentially in that fast decline, to prevent that from happening, or at least to modify the rate, and ensure for overall that we have a more supportive environment. So even when there are declines, we can optimize functional abilities. But of course, a key question that is asked is, when does healthy aging begin? And we need to enhance reserve before the age of 60. And that's clearly why we also need to connect with earlier life stages. So part of our question that we have is how we can do this to optimize well-being across the life course. And this goes beyond the decade of healthy aging because it includes research questions addressing what investments earlier on in life are needed to put people on that better trajectory, but that also have payoffs during the second half of life. And again, this is in light of multi-sectoral action, in social determinants are very important, as well as equity. And as I mentioned, it's through this longitudinal work that we can get this more dynamic understanding. And I'm going to come back with one example on older adults in terms of their approach to retirement in a few minutes. Now, I'm not going to discuss the life course approach a lot because I know that's the topic for the next series. But just to say for WHO, as we are part of a life course department, we are also engaging with centers around the world that are addressing life course, but not just the epidemiology, but also how we can actually address, for example, develop new regulations, new policies, working with communities to actually address what are the negative sort of exposures that occur, how we can change those, and how we understand that that actually contributes not only to the well-being of children or adolescents or adults, but also how that contributes to the well-being of older adults. One of our challenges is that we have very little information about adults. We have a lot of work now on children, increasing information on adolescents and youth, but WHO still somehow treats women as reproductive vessels and men as whether or not they have a range of NCDs. So we're trying to address this gray zone as one of our challenges in moving forward. I showed this slide from Neil Halfon from UCLA, by coincidence, who's done a lot of work on children and families, and not leaving it in the epidemiology only, but has worked incredibly hard with the California state legislature and different programs, not only in public health, but in education and in other sectors, to try to really make a difference in what sort of programs and collaborations are developed. So it's one example. There are many across from Europe and other places in the world as well. So turning to that example, I wanted to mention is that, you know, for older adults, that we need a lot more research on the ways to design interventions and systems that are fairer and offer flexibility. So this is an example from Ignacio Calabib in Chile, who's done who led an analysis of 12 longitudinal studies, again from the health and retirement surveys that we're all looking at, but also he focused on the economic and social policies that shape opportunities and choices for older people. And what they did is they looked specifically at labor market experiences of older people 5 years before and 5 years after country and gender specific retirement ages. Of course, in different countries, the comparability and it matters because some countries have a much greater proportion of people working in the informal sector, and this is very different for men and women as well. But I think this analysis was really interesting because they found that full pension age did not signify a one-time labor market exit, as many older people continue to work part-time or they constantly move in and out of the labor market. And these 5 different patterns on the y-axis kind of show the proportion of people who have these different sorts of, in a way, trajectories during this 10-year period. So this is also really important because even during this 10-year period before and after when people are potentially expected to retire, there is a lot more dynamism in what older people are doing. And this need for flexibility in systems is really important. And this is a message we want to convey to policymakers because this sort of tight correlation between education, employment, and welfare is really unraveling. And as we are having longer lives, it's not that we want all older people to just work longer, but we need to understand the flexibility in systems, and we definitely want to remove policies that are perverse. For example, those that force older people in poor health with limited financial resources to work longer, while older people who would like to work longer, they shouldn't be forced to stop working due to mandatory retirement ages. So I want to kind of spend the next few minutes before finishing to say that this sort of 10-year period, we're very delighted that we have a UN decade. There are not very many UN decades. So having a UN decade on healthy aging is super exciting. And I think that this decade creates kind of an urgency that we can actually, plan out what can we really do over the next 10 years. So besides those 4 specific action areas, the Decade Action Plan also identifies enablers that should be cross-cutting, that we should think about as we're trying to put these actions into place. One is really listening to the diverse voices of older people, but also those around them, not only older people. We also have to nurture leadership and build capacity. And this is at the national level, but also at the local level. We need to improve the way we connect stakeholders. You know, in a lot of our disease-based programs, that filters down also to actions that occur in countries. There's very specific stakeholders and interest groups around diseases. We need to ensure that around older adults, we can have these kinds of stakeholders who come together, because we don't want to look at older adults in terms of disease. We really want to look at older adults in terms of how we can optimize functional ability, irrespective of disease or their level of intrinsic capacity. And of course, we want to strengthen data research innovation. That's part of what we are all interested in, but we want to steer that in a way. Our interest is that there is applied work, and that it can actually accelerate implementation and scale up of activities. So I won't go into detail, but we did develop this overall pathway to optimize functional ability, to try to show that there is kind of 6 steps reflecting existing WHO research, knowledge translation, and scale up strategies that can be applied. One could think of it as a way of engagement where you want to clarify what matters, and this should be important not only for older adults, but also for decision makers, because they are the ones, we need their sustained commitment to enable appropriate resourcing and longer term investment. We want to ensure that we identify the interventions that not only support intrinsic capacity, but also improvements in environments. We want to be able to design and assess these interventions, and sometimes these need to be evaluated not only in one place, but in many places, because it's not only the what that matters, but it's also how can it be done. And in different contexts, people may innovate in new ways that are also then enlightening for other places. So we need to be able to share that learning. We also need to ensure that these interventions don't only reach those in the middle, or are not only targeted to those who are, let's say, the worst off. Remember that distribution of hand grip strength. We want to be able to shift the distributions in a positive way. And if we looked at the differences between men and women, between sort of other socio-demographic characteristics, we could have more in-depth discussion. But it's not only a cutoff point. We're really concerned about the continuum and how to improve the overall distribution as well. And then we want to be fast, because we have 10 years and we want to be able to show improvements. So we've been sort of preaching a lot, but one of the things that we did in the report that's documented is we also looked at what WHO is doing. And we realized that one of our key functions is to develop normative guidance that ministries of health around the world then often use in the development of their programs. And we found that when we looked at our WHO approved guidelines, which go through a rather rigorous process, that very few actually looking at the whole individual. So from not a disease-based perspective, but from a capacity perspective. And of those, we only had 3 guidelines with 14 recommendations focusing on older people. So we definitely need to do more ourselves to be able to synthesize information and also then say what can be done. So that's one of the challenges that we've put out for WHO. We do have one program that we are now developing on integrated care. It's one of those guidelines, but then even though once you have the guidelines, you need to have the tools to actually implement that. And we are in discussion now with a whole range of countries from around the world who are looking at how ready they are to develop programs for integrated care and what kind of tools they need. So for example, we a couple of years ago developed a mobile application so that older adults can tabulate information and get resources as well through their phones. Of course, not all older adults have phones, but this is part of the process of developing a range of tools. Finally, I mentioned that there were many, that we had 10 progress indicators that were agreed on by all countries, that they said, yes, we can be accountable for ensuring that we are doing these things. I don't have time to go into mentioning all of them, but what I can say is they range from, the first one is, does your Ministry of Health have a focal point on aging and health, to does your country have a longitudinal study? And this graphic shows that out of the 194 countries, which ones have said yes. The one on having a focal point has the highest. We have about 63% of countries that say yes, but then we have a lot of variation. We also did this over 2 time periods, and we can see that all sort of globally that we are making a little bit of progress over the last 2 years, but the progress is unequal and not fast enough. So this dialogue with countries to develop policies and to be quicker is really important. And one of the things that we did to advance that and get some insights is we had an in-depth case study with our regional offices and our country offices. We selected 8 countries, 6 for each of our regions. And then we also included India and China, because we know about 1/3 of older adults around the world live in those 2 countries. And with the ministries of health, we did an in-depth analysis of what is the range of existing data, not only on health, but from multiple sectors, and how is this data actually being used to make decisions? Fascinating also for each country, because many of the groups didn't know about the data from other sectors. And we're now working with national statistics offices who tend to bring in data from all sectors so that they can also better inform what is the data on older adults, and also because they're the ones who provide information on the indicators for the Sustainable Development Goals to ensure that we have disaggregated data for older adults. So that's one of the sort of spin-offs of being able to do in-depth studies with countries. I'll just give one example from Qatar, in that over the last couple of years, Qatar redesigned their national public health strategy. They went from a disease-based approach to a life course approach. And they really did it for 2 reasons. One, they liked the concepts of life course, and they thought that was compelling. But the reason they really did it is that when they looked at other countries and they considered, because they benchmarked themselves very competitively against other Gulf states and also against OECD countries, and they did an analysis and thinking through how can we improve our outcomes, they realized that a life course approach would get them quicker to where they wanted to go to have better outcomes. And it's through messaging like that and the actual analyses that we want to provide to a much greater range of countries, with the evidence, because it's not just the concept, whether it's life course or the concept of healthy aging, but it's also showing we can get to those outcomes that we want, that we value as a society quicker. And so I think my last slide is just to say that we know that we're not, when we discuss older adults, we are not trying to force a trade-off in investments for older adults versus investments in earlier age groups. But we do want to have a more fairer distribution. And one of the things we did as a kind of simple approach to consider this is we did an update of an analysis that the Institute for Health Metrics and Evaluation did, where we just compared development assistance for health. So that's in the purple bars. So this is from high-income countries to low and middle-income countries. It's overseas development assistance, but targeted in health by different age groups. Excuse me. And we compared it with disease burden. So this is DALYs in the gray bars. And it's not surprising that we see a much higher amount of development assistance in the first half of life, particularly for children under 5, and that we know that the disease burden increases currently with older age groups. But I think our message isn't so much we have to completely match these things, because in a way we're comparing two very different things, but it's more a discussion piece that we have an opportunity to improve the flow of international development, but also national investments. So we can have the right investments at every stage in the life course, so that it sets people up for every future stage to be better off, and that we should probably have more investments at older ages, also recognizing that people are living longer. So we need to recalibrate that investment approach. So I think that's really the kind of big tour I wanted to discuss, and I really encourage you to look at the full report. The full report is about 220 pages. We will be releasing, I think later this month, a 30-page version in French, Arabic, Chinese, Russian, and Spanish as well. So thank you very much.
Many thanks for this brilliant presentation. I think we have a couple of minutes for a few questions, and I take the opportunity to ask the first one. Your presentation and the baseline report clearly show what has been done so far and what has to be done in the coming decade. I was wondering whether there is already a plan for the next decades, the following decades. Is there a plan or a strategy from WHO for the future?
So thank you. I was just trying to stop sharing. It seems to not be working. So we have been asked to provide the next progress report in 2023. So that is what we're now thinking about, how we're going to do that. Okay,
step by step.
Step by step, and they have organized it has been organized that there would be a report in 2023, in 2026, in 2029, and then in 2030.
Okay, there was a very specific question in the chat regarding your slide on difficulties in BADL and the 37 countries. And the question was on the green point. Is it possible to know which country is this green point? It seems to be an outlier.
So as this was a baseline, maybe somebody can tell me how I'm not able to get rid of the slides. I want to, or maybe somebody else who's the organizer can just stop sharing my screen. I'm not. Okay, maybe now it worked. Okay. So as it was a baseline, part of the approach to collective benchmarking was we wanted to ensure that the idea was not to make a league table. Not yet. I mentioned Qatar. There are some countries that very much are interested to be compared to other countries. They have very specific objectives. But as this was a baseline, we agreed that we would show the information, the data. We would say which countries are included. We did a formal consultation with all the countries whose data we analyzed. That means a formal consultation through member states, so that they could ask questions about the methodology, they could feel comfortable, because if they didn't want us to provide information, we, as we are a member state institution, we could have a dialogue on why. We agreed for the baseline not to tag individual data to a specific country. However, it is our intent in the 2023 report to show examples on how countries have actually analyzed their own data. Because ultimately, we do the global comparative analyses to stimulate action. And we decided a league table was not the way we wanted to go right now. So I can't really, I know, of course, which country is which color, but it wasn't the intent. Those countries know, but perhaps in the 2023 report, we will be able to show more about specific countries. Of course, if you go to like the Athlos Project Group or our colleagues at the University of Southern California, who are sort of the nodal point for the health and retirement surveys, they can provide information by country. Our analysis that we did, though, I hope this is a satisfying answer of why I can't tell you which country that is in that dot.
Okay, I think Laurence Zemater-Bagnou appeared very quickly. Okay, do you have a question?
Yes, it's kind of a question regarding this very comprehensive program recommendations, because it's not really a program. And you mentioned the ICOPE guidelines for integrated care. Do you have other guidelines regarding other domains of your definition of or domains of healthy aging?
So unfortunately, we only have 3, and they deal with the ICOP one brings together those 3. We do have some on cognition, and we do have in this integrated care, which importantly also includes information and guidance for caregivers, which was a first for WHO. We're really trying to promote more. We have some recommendations in different areas. For example, we do have recommendations on physical activity for older people compared to younger people. But most of our guidelines at WHO still tend to be on specific diseases. And this person-centered transformation is now sort of in process. And I'm hoping it's one of the things over the 10 years that we can make a big difference in.
Okay, it's very interesting. I'm looking forward to read the baseline report, and indeed there are so many pieces that now are together and we need to move it a step forward.
There is a question in the chat from Eric von Helm regarding lack of age-specific recommendations for older adults. It's more difficult to recruit older people into intervention studies. Does that translate into a weaker evidence base for interventions and less recommendations?
So this is, I think, a common issue. And I guess we should try, as the research community, to dispel certain myths, and then where there really are barriers, try to understand how we can overcome them. And perhaps the COVID context can be a basis for, I think we've had a lot of social innovation out of necessity, and perhaps this can be one way we could change the way we have research, design and inclusion in terms of finding out how can we design studies where we attract older people and we ensure that we understand why it's difficult, for example, to attract older people. Perhaps we haven't listened enough to understand. Of course, there were many studies where they just didn't include older people, but that's a different issue. But if we really want, I think we should put our efforts to really engage on that citizen science approach. And I mentioned Cochrane Campbell Global Aging. They have put together Cochrane in general, but also Cochrane Campbell Global Aging has put a lot of effort into ensuring they have older persons as part of groups who can be part of evidence reviews, systematic reviews. And so I think this is something we can develop better. And maybe this is something we can think through with Cochrane or perhaps other groups on how this can be done. And I don't know if this is something that your university, the Unisanté has thought about. Given that you also have this longitudinal study that you have had for quite some time on older adults in Lausanne, and maybe learning from that would be important to share.
We are a couple of minutes late, but I suggest to take a last question maybe from someone or from myself. An important component of healthy aging is intrinsic capacity, which is the resources, physical and cognitive. It's in the conceptualization, it's very close to frailty. And some people see frailty as the glass half empty and intrinsic capacity, the glass half full. What is your opinion on that? Is it simple like that, or is there another difference between the two concepts?
So thanks for that question. I'm not sure if I'm the best one to answer, but this is, it's not my personal opinion. It's the discussion of our group at WHO. We have a clinical consortium for healthy aging. And this started back in 2013. And initially, the proposal was that it should be the Clinical Consortium for Frailty. And within a few months, there was a clear agreement that no, actually, it's going to be the Clinical Consortium for Intrinsic Capacity, because intrinsic capacity is the overall continuum. And it's not, the intrinsic capacity looks at all these different domains. You can add other domains if you want, but it looks at how can we think of enhancing, keeping a high level, and when there are declines, some portion of that could be thought of, because in geriatrics, this concept of frailty that Linda Fried, who's been part of the initial group that we had, and many others have been using, that we didn't want to exclude it, but we see intrinsic capacity as an umbrella with frailty as one part of it. And so really that's the way we've addressed it. And I think we're working with a couple of geriatricians, and we hope by the end of this year to have a short piece that makes that clear in terms of the way we would like to use the terminology and to ensure we continue have a very good dialogue with geriatricians who we know are using this concept.
Okay, I think it's really time to lunch. I thank you again for your brilliant talk, and I invite everybody for the next talk, which will be held next week by Professor Dainaku, and have a nice journey. See you next week.
Merci beaucoup.